Now I would like to request Dr. Jamini Wuli, EAC Twinsang, and additional George Wongchen to please come over the stage and receive a small token of love.
Also, I would like to request Dr. Holo IAB, Head and Neck Surgical Consultant in Reed Hospital, to please come on stage and receive a token of appreciation. Sir Lung, who is our president. Also, Sir Savino, our ex-retired director. And Ma'am Daisy. Thank you.
Timely and relevant. The first one is emergencies in dental offices and their management, which reminds us that preparedness, prompt decision making, and clinical confidence are essential in every dental practice. Second is oral lesions and their management, which reinforces the importance of careful diagnosis, early detection, and appropriate intervention in improving patient outcomes. I am confident that these sessions will greatly enrich our professional knowledge and clinical understanding. I would also like to express my happiness at witnessing such an encouraging turnout for today's program. The presence of a good number of participants from various districts is a reflection that it is because of the enthusiasm, commitment, and the growing spirit of professional development within our own dental fraternity. It is truly heartening to see colleagues taking time from their busy schedules to come together in pursuit of knowledge, excellence, and professional fellowship. Such participation is a positive sign for the future of dentistry in our state and demonstrates our collective commitment to strengthening oral healthcare services for our communities. As someone who has had the privilege to serve in the field of dental healthcare and retiring from the responsibility of Director of Dental Services, I feel particularly happy to see so many young and dedicated dental surgeons committed to advancing their skills and keeping pace with the rapidly evolving world of dentistry. Today, dentistry is growing at an unprecedented pace. There are new technologies, materials, techniques, and specializations are transforming our profession every day. Whether one is engaged in government service, private practice, specialized clinical practice, public health, academic, or administration, there are immense opportunities to excel and make meaningful contributions to society. However, while we embrace innovation and modern technologies, we must never lose sight of the very foundation of our profession, that is, our ethics, our compassion, integrity, and commitment to patients' welfare. It is said that a successful dentist is not measured solely by clinical expertise or modern equipments, but also by honesty, humility, empathy, and the trust that we earn from patients and our society. To our younger colleagues, I encourage you to remain focused, curious, ask questions, seek mentorship, and never stop learning. Lifelong learning is not merely desirable in dentistry, it is a professional responsibility. Continue to upgrade your knowledge and skills, explore new opportunities, and strive for excellence in whichever field you choose. At the same time, remember that knowledge without ethics can never sustain the dignity of our profession. Programs such as this continuing oral and dental education initiative serves as valuable platforms for exchanging ideas, refreshing our knowledge, strengthening professional fellowship, and fostering collaboration. I congratulate the organizers for taking this commendable initiative and for creating opportunities for continuous professional development among dental professionals. As we gather here not merely as professionals, but also as members of one fraternity, may today's program strengthen our bonds, encourage mutual respect and collaboration, and inspire us to continue working together to advance the standards of oral healthcare in our state. May today's session not only add to our knowledge, but also motivate us to serve our patients with
The
greater
programs it mostly confined to clinical section only. So I request the officers in charge of these COT programs to why don't we take up topics like dental ethics one. Then the second is that legal issues because in our state we don't have much more of these legal problems but in other state they do have many, so we have to be aware of these legal issues also. So why don't we take up one program on these legal issues. Then the last point is that why don't we coordinate with other Northeast states and organize either COT programs or other short conference so that we can have understanding and coordination among the Northeast states so that if we stand together, we can always have one voice and fight with the mainland of India. Thank you.
So far is that NHAK is now going to be considered as a center of excellence for the district. Now we have already installed one 3D monolith machine, and then I think it must be costing more than 1 CR, a little bit more than that one. And then soon the department, they are going to conduct a free orientation camp. So, of course, the NHK, from the managing director, they will be taking all the responsibility. But among us, it'll be on first come basis, first come first basis only. I hope so. So just keep in mind that it'll be a free camp, and then one fine day, if God willing, in your own setup, you may able to buy even that machine also. So at that time, it will be a good thing that you know. So now it's a 3D machine. You have to take the impression only, and then just watch some of the pattern over there, and then your CD will just come up within few minutes. So that all this are going on, and then it's a pilot project even for northeastern state also. So this machine is only installed in Guwahati and NHA as of now. So we are so privileged that even the department as a whole is giving such a privilege to our department. That's one thing. And then another thing that I was so impressed was that uh, government has given us the privilege to visit all the health units. That time, I feel so happy that especially in the three health units, all the programs and then the clinical part, whatnot, was been taken care by our own dental surgeon only. Even conducting the delivery maybe, because mothers will definitely come over there with the help of nurses and all. So it was very encouraging that people start noticing us, unlike the days that which we start our practice. So just keep in mind, and then as our former directors mentioned, Nagaland is such a beautiful place, why not we explore? And then I really congratulate the Wokha team that you have really taken such a great effort to host that one. And then even in Timapu in Kohima, so imani ahido. Only this much catering used to be there. So this is a huge gathering for all of us together. I wish all the best, and then I myself I won't be able to attend that much. I've got another engagement. So anyway, I've already got the certificate that he said. So ini polite job with it. But from the next onward, I think we better do in that line. Thank you for giving us the opportunity, as long as a gift that you've given us. It'll be a good memory. Thank you.
Inspect primary control bleeding. First of all, inspection of the soft tissue wound to locate obvious bleeding vessels. If present, then we should apply pressure, and if there is any arterial bleed, then we should ligate it with reabsorbable sutures. Inspection of bleeding from the bone, bleeding from isolated vessels, from bleeding foramen should be inspected. If there is a bleeding from foramen, then gauze and hemostasis should be done. Applying gauge pack directly over the extraction socket. Patient should bite firmly on gauge for 30 minutes once the extraction has been done, and we should not dismiss the patient until the hemostasis is achieved. Check extraction socket after 30 minutes. If bleeding is under control, apply a new gauge pack and instruct the patient to bite for it for another 30 minutes. If the bleeding persists and it's not of arterial bleed, then we can take additional measures such as application of gel foam or application of oxidizing regenerated cellulose, or we can apply topical thrombin. Gel foam is one of the most common employed agents for controlling of hemostasis in minor bleeding.
Studies by Yannick et al. They found that nearly in every 10 cases of oral cavity cancer is not arise in leukoplakia, and there's another study carried out by Kumar in the Indian subcontinent, and they found that the prevalence of leukoplakia ranges from 0.2% to 5.2%, and the malignant transformation rate ranges from the 13%, 0.13% to 10%. Mostly this leukoplakia is seen in the age of between 35 to 45 years, and male are usually more affected than female. Clinical presentation of oral leukoplakia, it is seen as a white patch or plaque on the oral mucosa, which is usually asymptomatic and may sometimes occasionally cause burning sensation, roughness, and mild discomfort. The sites that are mostly affected by the leukoplakia are the buccal mucosa. This is the most common, followed by the commissures, tongue, especially the ventral and the lateral borders, the floor of the mouth, the gingiva, and the soft palate. Leukoplakia can be divided into homogeneous and non-homogeneous leukoplakia, and then this non-homogeneous leukoplakia can further divided into three types. There is the speckled leukoplakia, medullary leukoplakia, and verrucous leukoplakia. When we look at the homogeneous leukoplakia, the features of homogeneous leukoplakia is that it is usually commonly whitish in lesion. It has a smooth surface, corrugated and membrane type can be seen on the surface, and then it has a creamy stripe with a pattern of fine lines, and sometimes it can appear as wrinkled or dry cracked surface. The non-homogeneous leukoplakia appears as mixed white or red appearance, and then it usually have an irregular surfaces, and then it has a high risk of dysplasia and malignancy. The subtypes as address the speckled leukoplakia, nodular leukoplakia, verrucous leukoplakia. These are some of the clinical presentation of homogeneous leukoplakia. We have we can see a well-defined borders with a smooth surface area on the commissure area.